My name is Jessica Miller, and I am with SHARE, the Self-Help and Recovery Exchange. So the title of this session is called Transformational Advocacy, Collaborative Genius. And this is brought to you by Shannon McCleerey-Hooper, who is a Deputy Director in a peer support services and Riverside University Health System Behavioral Health. Shannon received her Bachelor of Arts Degree from California State University in Fullerton, and considered a subject matter expert in peer support services within public health settings. She also has provided workshops across California in efforts to legitimize the peer support practice, which is really awesome, really amazing work. So I'm excited. I'm excited to have you here today, Shannon. So if you all are interested in getting a certificate for attending this presentation, please just put your name and your email in the chat, and we will send out certificates shortly after this conference. All of today's sessions are being recorded, and they'll also be available at a later time, which I can share the link with you. I'll share a link with you all at the end of the session to where it's being updated constantly, and eventually that we'll be able to upload all the recordings from today. If you have any questions or technical problems, you can reach out to me in the chat. You can chat me directly, and I'll try to help you resolve whatever issues you're having. So if everyone can just please mute themselves right now, and so we can give the floor to Shannon. She's asked that there's going to be time for Q&A at the end, but if you have any questions throughout it, I'll be monitoring the chat and trying to catch any questions that while she's presenting. So I think you can also probably raise your hand, and but if it's like probably a big picture question, maybe we can save it for the end. So with that being said, I'll let you take the floor, Shannon.
Thank you. Thanks, Jessica. You're so helpful. Thank you. Hi, guys. We have a nice small group. I love seeing your faces. This makes me happy. Hi, I'm Shannon. I'm from Riverside University Health System, Behavioral Health in Riverside, California. Disclaimer, or at least full disclosure, that I'm going to be talking in terms of California. Okay. So if you're from another state, some of this may be foreign to you, or may seem like, oh, well, we already do this, or we haven't done this, and this is really innovative. I'm hoping that's kind of where we go in this conversation, because when you're trying to transform a system, it's a difficult challenge. And I know that all of you, how many of you guys all work in peer support? You can raise your hands because I can see you all. So you guys all are peer support specialists. So there's a couple of you that may not be, but I love the work that we get to do in terms of being the catalyst for transformation for systems. And one of the things that we discovered in a particular project was that when we were able to collaborate with a sort of non-traditional group of people to work with, we managed to transform a system that needed to be turning a corner with regard to its paradigm, its cultural paradigm, as a system. So I want to share with you guys what we do in, oopsie, my slide won't go forward. How come my slide won't go forward? Oh, there we go. Okay. So in California, we have what's called the Mental Health Services Act. The Mental Health Services Act was passed by a proposition on our ballot in 2004, which taxes millionaires, which isn't me. It taxes millionaires 1% of their annual gross income. So we get this money that goes into a pot, and it's used for specialty mental health services, very specific to reach underserved populations, homelessness, reentry, people with very severe mental health conditions, the full service partnership kind of group of people. And when we write an innovations program, we write a project that gets submitted to us by the state and says, hey, we want to explore this thing. And so the thing that they wanted to explore was tech-based innovations with regard to how we access people, or how people get access to us in behavioral health system to receive services from the community level that will meet their needs. And the intent of a particular innovations project is really important. When they write the proposals, we have this great group called the Mental Health Services Act Administration in Riverside County, and they have their think tank at the county level, but they go out to the community and ask the community, what do you want? How do you want us to change? What are things that you're not getting that you want to get? And I, as a consumer, participated in some of those things as I was coming up through my recovery. I've been in mental health recovery for 30 years or so, and this asking us what we want is the important part of this piece. You can't get innovations money without doing that. The intent of the project was to get early detection for some populations of focus, to think about suicide prevention, to be improving the outcomes for high-risk populations, and utilizing the insights of peer supports or people with lived experience to inform or provide the guidance around the entire project. It was in the intent of the project, it was actually to write in peer support. And this was cool because when they wrote it in, Riverside County, I will say back in 2004, when MHSA passed, they enacted our peer support program almost right away. And by 2006, there were 17 peer providers that worked in Riverside County, 17, okay? We are 750 radial miles. We're the size of New Jersey state, okay? We're huge, but there were 17 peers for the whole system when they first started. But it was brand new, and there's all this stigma. They don't want to include the peers because they don't know what to do with them, and there's no guidance and all that. Cut to today, if you're talking about today, we have over 450 peers that work for Riverside County, Riverside County's system. And it's more than that, actually, because we have contract service providers that provide some of our peer support as well. So as a system, though, we directly employ 450 people, and that with lived experience, which is huge. So when they wrote this proposal, they went through this community stakeholder process, asking the community for feedback. And when they did this between February and August of 2018. And they went to the community, and they did this in all kinds of ways. They did focus groups, they went to parks, they went to community centers, they went to the, we have all these committees that work in our system, and I'll show you those in just a second. But they reached out and they did these about 100 different focus kind of conversations with the people that live in our communities. And when they got the stakeholder feedback, they took that feedback, and then when they went to write this proposal, they created a staffing pattern that actually required peers at the leadership table. Like the peers were the ones who are going to drive this project, and that there was going to be diversity on this team, because we have these populations of focus that we really want to be able to try to open doors for them so they can get access, right? So those were things that were written into this proposal. And then the counties that were going to participate in this project that the state put out to us said, look, we're going to try, we want technology-based interventions for people that you're going to be working with other counties, those counties who wish to opt in. Well, it came down to 14 different counties. And we found out when we did our stakeholder process that talking to these groups, you've got members of every kind of community you can possibly think of in these particular groups. And this is just a handful of what the sessions looked like. I just wanted to get an idea of who we talked to get information about how people need access to our healthcare services, right? But now we're thinking about technology. How do you make technology work? Well, who are you going to ask? You're going to ask the peer. So when we collected our data, it told us a story. And in that story, it told us that, yes, we have 52% of our population is Latinx. And the ones that don't have access or can't get access or don't know how to get access are migrant workers, monolingual families, rural areas. Riverside County also has the largest deaf community in the state of California. We have the School of the Deaf that just won the CIF championship for 2022 last year. Yay, yay Cubs. And so we have a high concentration of this population that we have to try to penetrate because culturally it's difficult to reach them. They have cultural barriers that go up in front of the deaf and hard of hearing community, and we don't serve them very well. And you would think that we would be great at it, right? Because we're right here, but we're not doing it. So these are things that we found out from the data. Also, that early detection piece that I talked about earlier in suicide prevention, specifically for young people, transitional aged youth from like 16 to 25, and men, white guys over 45. Who knew, right? So these are things that stood out, and we had to improve those outcomes, but also not just outcomes for those first groups, but really for the reentry population, people leaving incarceration. So necessary for the staffing pattern was the peer aspect of this project. And the peers themselves needed to be part of the process, one, and two, they needed to lead the process, which means we're not going to decide anything without the voice of lived experience. We are going to explore technology they might use, and then we're going to unveil the mysteries of technology from that peer perspective, like all of these peers looking at, what's so mysterious about technology. So you guys could probably name 100 things that are mysterious about technology. But what they found during this process is that digital literacy piece, understanding like what your footprint looks like and what you're doing on the screen and how it goes out into the universe, and the fear-based thinking that goes around technology. And that's something that we wanted to unveil, and then to explore the recovery skill of gentle curiosity. Okay, so as peer support specialists, we're very curious. If we are trained and we understand our core competencies of peer support, we get curious, and we get curious in a very loving way. And we ask a lot of questions, and we want to get to the bottom of how something works, or who is actually going to access this particular technology. And then the piece that was so important was the diversity on the team. When we selected people to participate in this in the beginning, we couldn't recruit for it. We had to take internal employees, right? People who are already employed as peers for our system. So we had a program manager, and the program manager for the technical side, the program manager is Latinx. She's a parent. She's a community member. The peer program manager at the time was a mental health consumer, a parent partner, a family advocate, and part of the LGBT experience. And then we had a senior peer who's a leadership mentor who sort of leads the peers, doesn't provide supervision, but provides support and partnership with the supervisor to make sure that those voices are honored at all channels. And that senior peer in co-recovery, then you have 3 peers that are on there that represent all these different communities. So when we selected these people, we selected them with intent, because we needed their voices at the table about what people might use. So this collaborative is called the Help at Hand Project, and I'm not the lead on the project anymore. We have a new program manager who's actually leading this project, and she's in charge of the peers on this project. But what I want to talk about is like the very beginning, the infantile stages of this project, so you can see kind of how this is going to influence change. So if you see Help at Hand, or if you Google it, you can actually go to their website and you can see what the Help at Hand Collaborative is. And that's those 14 counties that were exploring technology along with us. So one of the things we had to ask ourselves was, does it serve the underserved population? We had to ask, is it something completely new? Has it been done before? And can other counties replicate this thing? Can they duplicate it? Can they do it someplace else? And would there be funding in either their general fund or in their allotted funds that they get to be able to do this? So when you're doing your exploration, you have to keep that consciousness kind of at the center of how you're thinking about moving forward with this particular process. So the peer team right away started brainstorming and dreaming about, like, what could we give our people that they would use? And peers are really awesome at brainstorming. We know that. And we think about things. And what happened was they didn't have any idea where to start. I had no clue, right? Like, I don't even know where to start. Like, there's a million apps on phones. Like, what are we going to explore? So they started testing apps. There's about 150 apps that the peers actually put on their phones and utilized themselves as the consumer or as the parent or as the family member, as the young person, as the LGBTQ plus member of the community. They were looking at what we would use ourselves, what features we liked the most, what was off-putting by a particular app, and language came into a lot of it, because there's millions of apps out there, and they're all across the country. And when we were going through these apps, the peers were discovering that there was a peer support function on the apps themselves. There was peer support. You could click peer support, but they were all AI, artificial intelligence, and with intuitive text that would come back, and it was not like, it wasn't supportive, especially if you didn't speak the language. So there was this piece that kept missing. They kept missing it. And after reviewing about 150 of these smartphone apps and using the features and exploring wellness for ourselves, the consensus was that none of these apps, of the 150 that we looked at, had real peer support in them. None at all. Like, there isn't another real person on the other end of this conversation. And we know that peer support is about being with someone, right? And about having a conversation that is rooted in listening at the heart level. We know that. So they put Post-it notes all over this room, and they started writing down, like, what do we like about the apps? What are the things that we enjoy about the apps? Or what are the things that we responded to? What was positive? What was negative? And then thinking about what a perfect world would be in a particular app. And one of the things that we discovered was that real peer support really focuses on your emotional well-being, right? We're trying to address your emotional well-being. And usually that includes, the goals that you have in your life and your day-to-day living, and whether you can manage your money, or if you're eating, nutritious food, or whatever that looks like. And no real peer support in these other apps made us think about how we're going to access people who have stigma that's at the center of how they operate in the world, right? If you're thinking about these communities of focus, you're thinking about cultural stigma, you're thinking about structural stigma, you're thinking about institutional stigma, you're thinking about personal stigma or public stigma, or even my own self stigma. And so mental health, substance abuse, getting behavioral health help is not the way to go if you're going to try to reach a community that, if you can translate emotional well-being into another language, or to speak to somebody's cultural internal compass, you can keep it to emotional well-being so somebody wants to reach in, right? So why not lead with that? Why not start the conversation about an app that addresses emotional well-being? That universal approach that for people who may experience a great deal of stigma. And that was brilliance, absolute brilliance that happened in the room, with people without PhDs, people without any kind of alphabet soup at the end of their names. These are all people that have lived experience and do their jobs as peers. And that was exciting to watch. So we were very excited, and we took our idea to a meeting that we had with the tech team, where we were talking about, all the research we were doing on all these different apps. And the research team was very esoteric. Like, what can we do to our website? What are we, it was very the same old figures of things that we've always done, right? Let's use somebody else's app. Let's look at 7 Cups, and let's look at there's a whole bunch of apps that they were really looking at for us to gravitate toward, to offer to our consumers or offer to the public for free. And that's great. But when we shared our idea with the tech team and said, look, this is what we think. We think that if we created a live chat peer interface that has peers on the other end for real, in real time, for people who, one, maybe don't want to talk face to face to somebody, or that phone is 1,000 pounds and I don't want to pick it up, I can text somebody. And youth, right? Youth, all they want to do is text. And my daughter won't even answer my calls when I leave her a message on her voicemail. So if you text her, she'll text you back right away, but voicemail, forget it. So when we shared that idea with the tech project manager, she ran and told her web developer and said, look, this is what the peers think, and this is what they found, and this is all the information that they gathered. They were so inspired by what was being shared to them, by what we tried to do, we were running in the dark. And he was so inspired that after hours, on his time off, this man developed a prototype. And he started a prototype of this particular app, and he named it himself. That's the collaborative genius. His name is Rick Wright, and he is a genius, an absolute genius. He named it Take My Hand because he got from what we were sharing about what we do in peer support, made him think, oh my gosh, this could be something so cool, right? So sharing that idea and getting a prototype, he had the prototype done in 3 weeks. 3 weeks, that's how excited he was. And if you're at all a web developer, a person who does code, that is a lot of work. And he had it up and showed it to us, and we were super excited. Cut to the pandemic, wah, wah, right? So we get into this pandemic era urgency about, how are we going to help the community members who are so stressed out? People are calling 211 and getting, and bogging down the systems. 911's getting bogged down. There's a party in the backyard and I'm anxious. And there's this press release on March 4th that shows up in everybody's social media that says, we are in a pandemic. This is something, we're in lockdown. There's a situation where we all need to stay home. And during this time, just before this press release, I was actually invited to the executive team table here in behavioral health, which has never happened before. As a peer manager, I was the peer manager, and I had never been at the executive table. I had acquaintances with the executive team members, but I did not interact with them on a regular basis. And I got invited to the table because they were in a state of emergency, and our emergency operations center, the committee, had asked for self-care tips, wellness tips. So I just started showing up. I was just talking about how I care for myself and giving lived experience about how I'm dealing with this for myself. And the executive team became so excited by that interaction that they invited me to stay on the executive team, which was huge. So in an executive meeting, they were brainstorming, like, what can we do for the community? What are we going to do? Da, da, da. We're only in the baby steps of this development of this app. And during that time, I was reading a lot of Brene Brown. And, I go to the Church of Brene Brown, and the stepping into the arena thing was scary for me, because this is the executive team. This is a doctor. This is the director of innovations. This is the medical director. This is the substance abuse prevention and treatment and integrated programs director. These are all people that are at the top of the food chain. And I was nervous. I was really nervous. But I stepped into the arena in a meeting and I said, hey, I have an idea. Why don't we do a rapid deployment of the peer chat so people can chat about what they're dealing with and get support from peers? And on April 20th of 2020, our director of behavioral health, Matthew Chang, said, let's do it. Let's do it. And I'm like, oh my God, what did I get us into? What did I get us into? So that was really kind of scary, but it inspired other people later to reach out to us. CalMISA, you guys know who CalMISA is? If you live in California and you see on your TV screens, CalHope, text with us for support or call the 800 number for support. Well, CalMISA reached out to us because they were actually conducting that Help at Hand project and that collaborative. And they reached out to us and picked our brains about how we're going to train the peers and what we're going to do on the chat. And it influenced them to put CalHope together and create a live chat. So this is how innovations projects work. You have an idea, and if it can be duplicated someplace else and somebody else runs with it, then you've innovated something, you've created something new, right? So this innovation happened because not just because of the pandemic, because we thought about this ahead of time, but it was because we made it available to the community. So I'm showing you some very early advertisement and information that we provided early on to the community and to our stakeholders, to the people that work in our system. And it was just to talk about what it does. It's a chat interface using the internet, and it utilizes the practice of mutual peer support and engages community members in real time and helps visitors build resiliency when life is difficult. And so it had nothing to do with mental health. It had nothing to do with behavioral health. It was just about reaching out and getting support. Our early social media ads, we started, say, are you feeling sad? Are you feeling overwhelmed? These are just some things I wanted to share with you, just so you could see, how this is universal, right? And then as it progressed, we were doing things about, feeling alone because people were living on their own, and they were sheltered in place basically in their homes. And these things were bringing people to the chat. Now, at this time, when we launched it in April, we were 24/7. And we found out that during that time that we didn't need people 24/7, but we needed people until 10 p.m. And from like 8 a.m. to 10 p.m., the early morning hours, people weren't chatting with us that much. So, but these are things that people said about their first experiences. This is in the first 6 months of doing this. They said, lifted my spirits, gained some confidence. Thank you. Nice. And he's nice and he understands how I feel. Extremely helpful and helped me turn my mood around. I really appreciate her. Easy to talk to. I mean, look at these. These are just some of the things that people said early on. So in this project, we also had the peers built in for other things that we were working on. And what we were talking about was bringing more accessibility to the community. And we came up with the kiosk idea of being able to access behavioral health resources and support from kiosks, and not necessarily in a clinic, but in a library, at the grocery store, outside of the Salvation Army. So people could go from where they are in the community to be able to access this information. And Take My Hand ended up on those kiosks. So if somebody wanted to chat there in public, they could do it. On the landing page of the kiosk, there is this connection to care whenever and wherever you want. And then it shows different groups of people, and it rotates on our Help at Hand, or excuse me, as our Take My Hand advertisement. Now, we ended up doing some marketing. Oops, there's a kiosk. There we had a map locator too on the kiosk, so you could find out where you could find the other kiosks and clinics and things like that, which was kind of cool. But in the early marketing stages, we were talking about billboards and telling the public that we're here for you. And those were billboards all over the county. We also, and they were from all kinds of demographic populations. If you look at these are sort of trying to attract different groups of people to come and talk to us. And that was something that we had never done before. We had never done billboards before. Brand new, never done. And influenced, and our system now uses billboards in so many of their programs. It's incredible. But that idea came from the peer group. Following us on social media, this was, we post them every week. We have Take My Hand on our social media every week: Facebook, Twitter, Instagram. And then we had these cards that gave people instructions on how to use a QR code. I love the little guy in the middle. He's our chat bot that answers the chat after hours. And we have 3 of them. We have Luna. We have 3 of them that actually, they answer chats when we're offline. And it tells us that we're not on right now, but these are our hours, which is kind of cool. I've got some questions in the chat, and I want to kind of go through those really quick. So the peers on the chat responding are peer support specialists. Yes, that is correct. Every single person that works on our chat is fully trained in an 80-hour peer support training, a Medi-Cal certified peer support training, because Riverside University Health System Behavioral Health is also a training entity for the state. But we also have specific training for peers that is very much around the virtual environment. So they are trained to watch for certain types of words and phrasing, and what question to answer, or how to explore further with someone who is giving short answers, or recognizing a troll. So there's very in-depth training that goes on that we shared with CalMISA, and they have in turn shared it with San Francisco County, with Orange County, I believe, and with the CalHope team, which is kind of exciting. Let's see. Uh-oh, no, my slides won't move. What's going on there? I'm going to stop sharing and share again. Anybody have any questions so far?
I guess I just have another question is, how do you ensure, because I remember you saying that you have a diverse staffing with the peer support specialist. So when you engage in this chat kind of medium, how do you ensure you're getting a diverse,
So what's
you're
nice
meeting the
is,
diversity needs in responding?
yeah, so if somebody identifies something specific in terms of how they identify, if they're looking at you as your picture, because we use our own pictures on our chat profiles. So if they get somebody, some white lady like me, and it's a kid in the community who, who doesn't identify with me at all and doesn't feel comfortable talking to me, they can ask for a particular type of a person if they want, and we honor that. And we'll find somebody. Oftentimes we interface with people who are coming out as trans, or coming out as gay or lesbian, or wanting to have that conversation with their families. And we have an entire group of people here that actually identify from the LGBTQ plus community. So that's been the benefit of this, and we have, what's nice is that we have a Spanish interface on our website. So if you go to the website, you can click Español at the top, and this is what comes up. And you can converse in Spanish. And we have a translator if we don't have a Spanish speaker, but we have plenty of Spanish speakers on our team that can answer those threads in Spanish. Because our population is 52% Latinx, you got to have those folks on the chat, right?
Right.
So that was an important piece of the puzzle. And then what we did too is that we started hiring family members too, because families were having difficulty with their young people under lockdown, and especially families who have kids or siblings or husbands or wives that are either substance addiction, or they're dealing with their own mental health challenges. These are things that could be addressed by a family member, and we have family members on the chat as well. Deaf and hard of hearing community. So this is some of the advertising we started using, and we actually are working on adding, it's actually in the interface now, but it's not activated because we don't currently have contracted or employed deaf peer support specialists, but that's our next goal, is to get there. We did our first deaf peer support training in the community in October of last year. So we're getting closer, which is really cool. We had people who graduated as peer support specialists who are also deaf, which was neat. So this is what it looks like today. And what's cool is they just released our smartphone app. So if you have an iPhone, you can load it to your phone. It's not for Samsung yet, not for those phones just yet, but they're getting there. But that's where we are today, where we actually have a smartphone app that's in the Apple Store, which is really nifty. So what I wanted to say was that this process of transformation, it's created a whole bunch of different things for us as a system. The research and technology team reaches into our lives, to the peer services side, and asks us questions and asks us for our feedback. the executive team kept me as a permanent member of the executive committee, and actually I was promoted to deputy director, so I could be on the team and an equal with the members on the team in terms of my title and my role, which was very exciting. It had never happened before here. So that transformation doesn't work unless you're writing it into whatever it is that you're proposing. If you're going to propose a change or a different way of doing something in your system, it's very important that you include the peer voice when you're actually doing the architecture of your project. And really, I think it keeps freezing. I don't know why it's doing that, but well, I don't know where I am in there. Bear with me just a moment. Technical difficulty. So what comes up for you guys in terms of what I've been talking about? What comes up for you specifically? You can unmute yourself and tell me what you've been thinking about while I've been blabbing.
Honestly, when this first session began, I was thinking something totally different when I saw the words transformational advocacy. So my role is I'm a public policy coordinator for the California Youth Empowerment Network, a program of Mental Health America, California. And so I was thinking like, oh, this is going to help me better, work on policy in this area, in this space. And so it kind of touches on it a little bit. And I think it can be very, it can transition a lot of the stuff that you were talking about over into my realm. But yeah, that's just what was going through my head. It's like, how do I translate this to my space and area?
I love that you brought that up, because writing policy is important. And if you're not writing specific peer policy at your system level that involves the peers in that policy, then it's not going to work. But it's not what doesn't work is if your leadership doesn't honor it, right? And at MHA, you guys are lucky because you've got a whole realm of people that are at your leadership level that are peers, right? So you've got like what makes transformation for your system. Transformational advocacy has to happen in a system where their transformation really has to happen. And in public health systems that are not agency partners or community based organizations, they have that built in. They don't need to transform that much because they're innovative in their own way, right? So when you're talking about a public health system honoring a peer voice, it's a very, very hard sell. If you're talking about some of these larger counties or these isolated counties, they don't even have a voice at the table when it comes to deciding, recruitment. If you're going to recruit a peer, you're going to have to recruit a peer with a peer. And there are so many systems that recruit peers with their supervisors who are clinicians. And having a clinical supervisor be part of that recruitment process is important because they're going to work under their license, right? They're going to work in their facility. But if you don't put a leadership peer with that supervisor to recruit your peers, you're going to set yourself up for failure, or that peer's going to be set up for a situation where there is no support in terms of that. That's built into that's a peer model built-in thing. Now, training supervisors, I'm all about that. We train supervisors. I do the Supervisor's Guide to Peer Support. Some of you have been in it, I think. And that when you're writing policy, Danny, it's important that you're thinking about how do you transform your system, right? I'm thinking about transforming a system that's very old school, right? And the fact that the peers are at the table for all these different things that we're doing is gigantic. It's something that you don't see in public behavioral health. Any other thoughts?
Thank you. That was great. Thank you.
Yeah, you're welcome. Any other thoughts that come to mind?
Bonnie put something in the chat.
Oh,
Do you want me to read it?
Open it. I can't move my slides anyway, so it doesn't matter. I think this is transformational in the sense that peer advocacy was what brought about this innovation project, and in a system that traditionally has not included peer voice, hence transformational advocacy. Yes. Can you share the Supervisor's Guide to Peer Support? Oh yeah. You guys want to know what that is? You want to know about the Supervisor's Guide to Peer Support? Okay. So let's talk about that. So under peer certification, Medi-Cal peer certification, supervisors are required to take, if they supervise peers, they're required to take this 1-hour course online at the SAMHSA website. That's fine, cool. You get whatever you have to learn in an hour. We teach an 8-hour course in Riverside County. And that 8-hour course includes so much. It's not just about you get the supervisors in the room and you ask them to identify, what do you want to learn? You know, what do you want to learn? What are your learning priorities, right? We ask them that. And they're like, well, we want to know, like, well, can we talk about somebody's not wellness if it's compromised, or can we, you know, what do I write the person up for? And da, da, da. So we write it all down, honor their choice to talk about these things, right? And then we go through what we go through what the state is requiring of peers. Here's the thing. The linchpin is CalAIM. In California, the CalAIM initiative is making sure that we're seeing the human, right? We're going to see the human. We're going to give them love and support. And we are going to honor the peer voice, because peer certification is now something at the state level. And of course, we're one of the last states in the entire union to do this, but they have made it very clear about what peers are allowed to do in their therapeutic activities, in their educational groups, in their support to families. There's all this stuff that's written into the rules, which makes it an open playing field for peers to provide services to anybody and at any time, because the pre-assessment time, peers can do work and bill for it if they're certified, right? So we talk about that with the supervisors, and we talk about we show them the core competencies of peer support, and then we follow it up with the Medi-Cal Code of Ethics and say, coercion is not part of our job. If you're requiring somebody to come in to get their meds, to get their check from the payee's office, that is coercive. I am not participating in that. It's outside of my code of ethics. And when we start to define very intricately the peer role, that we walk side by side with somebody, we don't do anything for them. I'm not going to do things for the person I'm serving unless they're completely incapacitated and they need my support to get something done. I am not going to do something for you. I'll do it with you. You need to call the landlord. Come in here. Let's do it together. You can press the button, right? You can mentor somebody through that stuff. It also talks about the exam. I've taken the state exam. I'm certified in the state of California. It was one of the very first, which is very cool. And we talk about what we have to prepare them for. And that freaks the supervisors out. They're like, oh, they have to pass an exam? Yeah, they have to pass an exam. And these are the kinds of things they're going to ask them on the exam. And if you're asking them to do this, 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 and this, they're not going to pass if this is the habitual way they are providing services, because you've trained the peer right out of them because they're becoming little mini clinicians. We don't want that. And the state doesn't want that. The state wants us to stay in our role. They want us to self-disclose in a meaningful way that helps another person move through their recovery at a pace of their own making, and to be able to provide that lived experience in all kinds of circumstances, not just with the person, but at staff meetings, at our service events that happen in the community, our outreach events. These are things that they're telling us that we have to do. And we tell the supervisors that in this class. We also ask them to do a little mini rap, which is fun. Because we offer rap to anybody who wants it in our county. Like we've started with supervisors and administrators, and we framed rap not around a mental health condition or a substance use addiction. We said, have you been divorced? Have you lost your house? Did you get in a car accident? Did your dad die? Is your sister a meanie? These are all things that we could write raps around. So this is what we're going to do. I want you to identify what it is that you want to do your rap around. I want you to put it on a little card, and I'm going to keep it to yourself. You don't have to share with me what it is. And then we're going to go through the rap. What we do when we have this class with the supervisors, their eyes open, which is, it's not just about how you supervise peers. It's how you supervise everybody. Because it influences recovery at the clinic level in a way that says, look, you need to look at yourself And what practices, what are you doing well? And SAMHSA says that we have to say, okay, look, you got to be educational, you got to be administrative, you've got to be supportive. Those are the three things that you have to be as a supervisor, right? And they've identified those things. Well, we explore that very deeply. And we ask them, okay, so what does supportive mean? What does administrative mean? And how much of this are you really good at? I'm going to point out your strengths. These are the things that you're so good at. What do you think that you would like to improve? That's the peer experience, right? That open-ended question, we're asking them to answer it. And so it's basically a peer support class for supervisors. and it really does dive into, and then they have to role play. They have to look at a scenario of their own that they have to read. And one of them has to be the peer employee. One of them has to be the supervisor, but we don't ever say peer employee. That's your employee. This is you, because I'm not going to separate people by their role in the system. And we shouldn't as supervisors either, right? And we pass judgment on people a lot as supervisors. We are very judgy. And so what we try to teach the supervisors or try to facilitate for the supervisors is to get them to start thinking in terms of wearing compassion. I have compassion goggles. Where are they? They're on my desk. I have compassion goggles. I got to give them to you. Show them to you. Breaking stuff. Sorry. So we talk about if you are thinking in terms of seeing somebody for what they're going through or what's happening with them, right? There are days where somebody is just on your last nerve, right? They're in your doorway 14 times a day. And we talk about that. We say, you know, it's great. It's supportive to tell your employee to go make a list of all your questions. And then we'll meet at 3 o'clock. And I'm going to give you 30 minutes and we're going to go through every single one of these questions so you can get them all answered, right? Real tools, real-time tools. So these are my compassion goggles. We put these on when we're judging people. I have a pair in my car. People think I'm a lunatic. If I'm in my car, because I become a completely different person in the car. If you pass me on the freeway or you cut me off, I have all kinds of interesting words that come out of my mouth and a different head that pops out of my shoulder. And I have to put on my goggles and say, okay, you know what? Maybe his wife's in labor. Maybe he's trying to get to his kid. Maybe there's something that I don't know because that's the story I don't have, right? And if we have this conversation with the people that we're trying to train and we give them the insight of the peer experience, that's the only way they're going to connect the dots. And it's so funny because it's surreptitious. The supervisors sometimes after class will come up to us and cry and say, this is the first time anybody ever asked me to explore my own sense of wellness or my own sense of boundaries or my own sense of what it's like to just be a human being. And because it leaves us, we get burnt out, right? We see the people at the worst. They're very worst when we work at clinics. And understanding that we got into this business not for the money, especially in public health. We got into this business because something happened to us, right? We had an experience of our own. And every single supervisor will usually identify that. They'll say, yeah, it was my mom was not well and or I was a child of an abusive household or whatever. So really, in a nutshell, that course in itself, and it's available to anybody. Anybody can come take it here at Riverside. So if you want to come, you can email me and I'll put my email address in the chat. It looks like I have another question. What happens if once certified, you keep getting pushed to be junior mental health workers or clinical or clinicians prefer for my name to remain anonymous? Jessica, ask me that question. Open your mic.
Which Jessica?
It looks like Jessica Hicks. Sorry, Jessica Miller.
Okay.
Jessica Hicks. Jessica. She may not be here anymore. Oh, my mic's not working. Okay. What happens if once certified, you keep getting pushed to be junior mental health workers? Okay. So let's talk about the difference between, this is transformational advocacy for you. So I wanted to remain, oh, there you go. Oh, sorry. My bad. So, when you're working for a system and the system itself doesn't honor the peer role, they don't honor the title of peer support specialist, they don't acknowledge your role as a peer, because this is the thing, the difference between a community health worker, a behavioral health specialist, or a case manager, and a peer. Peer is the only one that is the only job class where you are required by that job class to be a person who self-discloses their own lived experience of recovery to help other people move through their recovery experience. It's the only one. There is no other role in the service system in any agency that has that role. So if you're a person who works for a system that calls you a community health worker, then that's an administrative challenge. We identified early on in CalAIM, because CalAIM asked us, do you want to do community health workers for your ECM teams? And I said, no. ECM teams are people who connect people from behavioral health to the health plans, right? Well, who does better navigation than peers? Who understands the peer experience, the behavioral health experience, better than the peer? So if you're going to hire a community health worker, that's great. Hire a community health worker, but don't put them in behavioral health. Put them in the health plan. That's fine. They can do that. Or if there is a situation where you're getting called something different and you know that you're a peer support specialist and you're a certified peer support specialist, that's advocacy that has to happen for your system. That may mean contacting human resources. It may be contacting your director. It may be contacting your supervisor to say, look, this is a solidified and legit role. Okay, we're legit. I have a t-shirt that says legit with a green ribbon on it. You guys would love it. This t-shirt that says legit means that I am legit. And the state, Governor Newsom made us legit. And we've been legit, though, for years and years and years. I mean, I've been doing this for 16 years now. I was a school teacher before I came to work as a peer. And that role has been legit all along, but they've legitimized it through the certification process, and it needs to be honored because it's an important piece of the treatment team. This is the thing I tell people. I show them two pictures, show them the same picture, actually. One is a puzzle and one is watercolor, and they're both sunflowers because sunflowers are my favorite. But I have these two pictures that I show. And I said, what do you think a peer should be? Should they be part of the watercolor or be part of the puzzle? What do you guys think? Watercolor, puzzle. What do you think? Open your mics, tell me.
Watercolor.
Okay, that's one. Who else? Bueller, anyone? Bueller.
I'm gonna say both.
Okay, both. Okay.
Yeah.
So this is what I'm going to say. A watercolor is blending in together. All the colors are muted and you're blending together and nobody has any kind of discerned identifier, right? You're all blended together. But if you're talking about a puzzle piece, that puzzle piece has defined lines around it. The clinician has defined lines of their competencies, of their indoctrination. The physician does the same. The office assistant has this role, and it's this puzzle, it's this beautiful picture. But here's the thing. If one of those pieces of the puzzle is missing, which is the peer puzzle piece that's missing, the person at the center of that photograph or that picture is not getting a whole treatment team. They're not getting every piece of the puzzle. So I like to ask people to think about themselves as part of a puzzle on their treatment team or in their organization, because you have a defined role. It's been defined for many years. It was published in 2011 by the International Association of Peer Supporters, and SAMHSA published it in 2011 for what are our core competencies, right? But the state of California made it legit in September of 2020 that role stays the same. It hasn't changed. If anything, it's made it even broader in terms of what we can do and what we can bill for. The new billing codes have become this wonderful umbrella under which we can bill that does not give us any restrictions about the things we do with the people that we serve. I used to get hassled at the clinic level about taking people grocery shopping. Like, why are you taking people grocery shopping? And I'm like, because this person has $120 to last them for 2.5 weeks. So we're going to go grocery shopping. We're going to talk about budget. We're going to talk about healthy food. We're going to talk about the constraints under which they can actually cook, you know, and I'm going to help them do that because I know what that looks like. Right. So, oh, thank you for the wealth of knowledge. I do need to hop off. Have a great day. Okay. Bye, Danny. Danny had to go. What else? What else do you want to know? When you advocate for change, using a loud voice and getting people involved is great. But having your leadership on board, getting somebody at the top to buy in is so important. We have that here. And so I have a lot of leverage, you know, to do things. And my boss rarely tells me no, unless it's to wear my compassion goggles in a meeting. So those are things that I have the benefit of, but it wasn't like that all the time. When I started in peer support, I showed up at a clinic and nobody knew what to do with me. I'm an educated person with lived experience, and I'd go to shake somebody's hands and they'd hesitate because there was so much stigma. And I think that if you're going to start changing things for your system, if you're going to start new projects, or if you're going to advocate for a job class change, you've got to get somebody on your side that is higher in the food chain than the ground floor of the supervision pool, or maybe even a manager, or even maybe a city council member or a board of supervisors member, somebody who will listen to you. And if you show up to your, you know, your board of supervisors or your city councils and you talk about this stuff, because really that's the only way change happens in terms of like old systems that are hard to change. I completely agree about how essential it is leadership to get on board. You are to be commended for the process of sticking with it and teaching leadership about peer support and why it matters. Thank you. I'm sticking with it. 16 years of sticking with it. Blood, sweat, and tears, and a lot of tears, I will tell you. But I want to say, I just want to inspire you. I want to inspire you to take your ideas and bring them to unconventional spaces. We had a guy, I just got called the other day to talk to the district attorney's office for an hour about mental health wellness, and I couldn't do it because I wasn't here, but somebody else took care of it. But I thought, oh, what a great opportunity, because that's the kind of room I want to be in. I want to be in a room with people who don't know anything about this, or are going to look at it and go, oh God, we have to talk about mental health again, you know. I only going to change your mind about what mental health looks like, because yeah, I'm kind of in a good place and I'm doing well, but it ain't perfect. And the peer experience itself is this, you know, recovery happens, but it never ends. It never ends. And I really mean that. And I appreciate you guys very much for sticking with me and without my slides. Improvisation, you know, right? Anything else come up for anybody before our time ends? Because we've got 15 minutes and I just wanted to know if you guys have anything you want to talk about.
Hi, my name is Julie. Hi.
Hi, Julie.
I'm a program manager for a wellness center in Northern California.
Yes.
And I'm a peer support specialist certified. And
congratulations.
Thank you. And I'm also a route facilitator, an advanced level facilitator. So I'm training.
That's awesome.
So I'm training other people to become route facilitators. Yeah. And my county is pretty not really very educated about what peer support is. And up until like this last year, the mental health treated peer support like they were transportation, like go pick up this person and bring them here. And
exactly. Yeah,
And
yeah.
so- Yeah, and so we've
I'm
been
the bus
fighting
driver.
against that a little, huh?
Sure.
Mhm. So we've been really working against that, and right now I'm working to advocate for the peer support specialists who work for the mental health, the county mental health. I'm advocating for them to be able to become facilitators for RAP. They've all
Yeah.
done the seminar one, and they've done that, and they've been working with us and helping. And I'm having trouble with their supervisors are not peers. Like the person who is supervising all of the peer support specialists is literally just got hired and is literally learning about peer work right now.
Right. Right. Oh, I wish I could get my hands on that person.
Me too. Well, and I tried, I embraced her fully and explained how supervising peers is so much different in my experience than when I supervised people who weren't peers and before I identified as a peer myself.
Yeah.
And that I would be happy to support her in learning this, and I have sent her everything I could find about peer supervision. We are considering with another organization here starting a peer supervision support, a virtual group that is
Good.
support for people who supervise peers.
That's
So,
awesome.
because I feel like we have some kind of unique support needs that I need to hear from other people who have similar challenges in that supervision, and I just want to provide the best supports. Is there something like that already that exists? I don't want to duplicate services. I don't want to reinvent the wheel, but I'd love to be able to have, even just once a month, be able to get together with other people who are making similar decisions that I am, so that I just feel like I'm out here on the road all alone.
Well, yeah, and that's isolating. You're like, but I love that you're advocating for people to get together and talk about it. The common challenges for peer support that I think that supervisors struggle with are the personal boundary thing. And I think that and also from a clinical standpoint, because a lot of supervisors are clinicians, right? And they become the therapist for the employee, which is a no-no, big fat no-no. Don't diagnose me. Don't talk about my behavior. Don't talk about what you can do is talk about my professional behavior. You can talk about, look, you're not showing up to work on time. This can't happen. And, if it keeps happening, we got to write you up. We got to start with the predisciplinary process. And we'll do that. But I need to get you some support. And me being a peer, I'm a person who'll say, look, in my lived experience, if I don't have a wrap for how I'm going to go to work the next day, I can't function. I have to pick up my clothes the night before. I have to meal prep on Sundays. These are things I have to do to stay well. And I do that. And I speak from my heart here. This is the stuff that I have to do every day. And then these are things I have to do for myself occasionally, just so I make sure I have to pre-plan a day off every 3 months. I need a Monday off so I can get a 4-day weekend or a 3-day weekend, whatever that looks like. I need to do that for myself. I'm role modeling that for you as my employee. I'm showing you that these are things that we can do for ourselves. And I want to say that to you, but the decision is yours, right? Or a person pushes back and says, I don't want to work with that client. Well, you need to work with that client. It's going to help you grow. And if you don't want to do it on your own, let's do it together. So these are the things that we train in that supervisor's class. We talk about all that stuff, but these are things that people need support around, and having a support group for supervisors is fantastic. I actually wish we had one here.
Well, we wanted it to be virtual all over the state of California.
Fantastic. I'd participate.
You would? Cool.
Yeah, oh, totally. I would totally participate. I'd be so into that.
Okay.
I'll be your huckleberry.
Awesome. Okay.
Yeah.
I'm writing down, is your email address in the,
I can write it in the chat.
okay,
I'll put it in the chat
thank you.
if I could find it. My computer's acting so strange. I'm surprised you guys can still see me.
So we started here in our county, we have something we call the peer work group. And so anybody who works in peer support in the whole county is invited. We do it on the 2nd and 4th Fridays of the month, early in the morning. And it's part skill building and it's part support. And we have peers who work in children's services, peers who work at mental health, peers who work for the police department. We have
Yeah.
all the different peers we can get together, and then we all, half of it is support. But from that, I decided I really wanted something similar, but for supervisors.
I think that's fantastic. I love it. I love it. Yeah, we've got peers everywhere, 467 of them.
Wow, we have 6.
Yeah, I know. You dream. I dream big, baby, and I act as if it's going to happen anyway because people think I'm delusional and grandiose. That's fine.
Right. Nice.
All right. Well, you guys have been wonderful. Thank you, Julie, for your remarks and your discourse with me right now. It's good stuff. If there are no other questions, no other things that you want to talk about, because I have my computer decided to fail me, I want you to know that you all have the power to change the world, and you all have the power to influence the people around you. And I am I'm really very blessed and grateful that I could be here and share my insight.
It was wonderful. Thank you.
Thank you, Julie.
I'm not seeing your email address.
I just put it in the chat.
Okay, let me see.
I'm not seeing it either.
I'll try again. Let's see what's happening here.
I'm going to put mine in the chat too. And if anybody else is interested in participating in that, please reach out to me.
Can you see it now?
No, are you
it's
sending
going
it to an individual?
Oh, it's a direct message. That's why. Huh.
Yes, okay.
Hold on. Let me try it. To everyone in the meeting. Let's try again.
There it is. S. McCleary H. at ruhealth.org. Awesome. Yeah,
Right.
so I just want to say thank you really quick to you, Shannon. I love your energy about what we do, and it's really great to see somebody advocating for peer support specialists and just peer services in general, and how impactful what we do is. And I wouldn't have gotten sober without people treating me like an equal, and like kind of like normalizing like basically what we do as peers. Like I wouldn't have gotten sober without like that unconditional love that and care and concern that peers really offer, and through like relating and disclosing our lived experience. So anyway, I just want to tell you thank you. I'm rambling now.
Okay, Jessica, that's cool.
So and you held down the fort even without your PowerPoint, so awesome job. So it was very
Plan
good.
for anything, just keep talking. I was in theater in college, and I did musical theater for years and years, and it's like vamp. You're gonna vamp until the guy enters because he's like late.
Yes.
It's the image that always comes to my mind. But it's fine, we'll make it work. I just appreciate having a platform to share, what I'm learning, and I keep learning every day. And you got to stay teachable. You've got to stay in a place where you're open to new things. And when they told us that we were going to be part of that tech project, I was tripping. I'm like, oh my God, what are we gonna do? How are we gonna be? What is this gonna look like? I was being all negative. And then we started working, and I was like, oh hey, we got something here. So it's very cool. Very,
Totally.
very cool.
Yeah, that's awesome. I love it. Okay,
I have a question for you, Jessica.
Mhm.
So I went to like 3 of these different things, and I didn't actually put my name in the chat for a certificate. Should I just send you a list or something of the ones that I went to?
So you can also do this. I just put it in the email. Brian at shareselfhelp.org is the email that you can send. You can send him an email with the title of the presentation and the subject line, or since you have many, I would just say, hey, I attended all these presentations.
Okay, cool. I'll do that. I just spaced and forgot.
Totally. This one, your information is in here, so we can we'll send you you presented, but we can still send you a certificate for it. So
okay.
Okay, so our next, I'm gonna kick you off the screen if that's okay.
Yep, I'm out. I gotta go for a minute because I have to, nature call.
Okay,
Take care,
yeah,
y'all.
thank you so much.
Thank
Take
you.
care.
Have a great day. Okay, bye.